on decoding anemia, diagnosis and management with the relevance to GA tract. Now I request our Dean Sir, Dr. Prasad, to give his address.
Yeah, good evening, good afternoon, Amta ma'am, and I welcome Dr. Ravi Shankar and speaker Dr. Bharat Kumar and Yashoda ma'am and all participants. It's very good topic, decoding anemia, diagnosis and management with relevance to GA tract. Funnily, GA tract may cause anemia and anemia may affect GA tract. So it's a good topic, and I congratulate Amta ma'am and Ravi Shankar to pick up a nice topic which is relevant for the general practice. And I think all participants may be enlightened with this talk, and they can update their skills and knowledge. And definitely, Dr. M. Bharat Kumar will give a nice talk enlightening this anemia. Thank you very much.
Dr. Bharat Kumar is a consultant gastroenterologist from Apollo Hospital in Chennai. We will directly go to the speaker, sir. Over to you, sir.
Yeah.
Over to Dr. Bharat Kumar.
Madam, can you see my screen?
Yes, sir. Yes, sir.
And the sign in to see adala varudha?
Yes, sir. Varudhu. Name varaikku vandirukku.
Oh, right.
Everything is perfect, sir.
Verum decoding anemia mattum theriyudha.
Decoding anemia with Dr. M. Bharat Kumar adu mattum theriyudha. Adukku munadi nariya slide vandhudu. Ipo idu mattum dhaan theriyudhu. இப்போ இது வந்துருச்சு சார்.
இல்ல மேடம் வெறும் ஸ்லைட் மட்டும் தான் வருதா இல்ல ஒரு I am seeing something else also.
Only slides
yes.
Okay, but one second. Okay. So okay, madam. Is it okay if you can see the slide?
Yes, sir.
Make it full screen.
Full screen.
Earlier it was full screen.
Yeah, one second.
Yes, sir.
Yes, sir.
Okay.
Full screen size. Full screen.
All right. Okay. So I'm going to talk on anemia actually. And it was a talk which I gave in SRM when they for their gastro meet. This is basically an overview of anemia. I'm going to talk about the various aspects and concentrating a little bit more on the GI part of it. So basically going on to, by defining anemia, it is reduction in red cell mass by definition. Pathological diagnosis or definition is by we have to call anemia as if there is a reduction in red cell mass. But the functional definition is reduction in the oxygen carrying capacity of the blood. That is why by definition is anemia, which is predominantly the reduction in the oxygen carrying capacity of the red blood cells. The normal hemoglobin is represented as a range, and it varies from various labs, and several cutoffs have been used. And generally, the basic levels are, for men, it's between 13.5 to 18. For women, it's from 12 to 15. And for children, it ranges from 11 to 16. And it is varied in pregnancy and depending on various trimesters. But generally, it is usually a range which is given based on the various labs. Madam, just give me 1 minute. I just came to my room. I just wanted to get some technical assistance from the other gentleman. That's the reason. So, getting on to the basics of how do we go about interpreting and reasoning out or decoding anemia, we need to know certain basic principles or how our red blood cells are being formed. Hematopoiesis, by definition, is production of various components of the blood cells from the stem cells. Hematopoietic stem cells have the ability to differentiate into the various cell components, which includes the white cell counts or the platelets or the red blood cells. Erythropoiesis, by definition, is production of red blood cells, and it's a regulated process. And erythropoiesis defined is a regulated cell production, red cell production under various influences of the growth factors. And the most important growth factor for production of red blood cells is erythropoietin. Erythropoietin is the regulatory hormone. Erythropoietin is produced by the peritubular capillary lining cells from the kidneys. And that is the regulatory hormone for red cell production. So under the influence of erythropoietin, red blood cells are produced and thrown into the circulation. And erythropoietin is very closely related to tissue oxygenation. It is linked to the tissue oxygenation. And if the tissue oxygenation is poor, erythropoietin production will be more. And with erythropoietin stimulation, red blood cells the production can increase 4 to 5 fold within 2 weeks' time. So that is one of the important armamentarium which is being used. And as we see in most of the kidney disease patients, erythropoietin is not produced quite well. So most of the hematologists will use this as a first line for production for improving the anemia by giving erythropoietin. We are able to mobilize and we are able to create a regulated production of red blood cells. And the mature red blood cells are of 8 micrometer in diameter, and they are anucleate and discoid in shape and extremely pliable. They can go through all sorts of narrow junctions and they can be extremely pliable. And the lifespan is 100 to 120 days. And the raw materials needed for production of red blood cells are iron, folic acid, and B12. With these raw materials in place, our bone marrow produces red blood cells and throws into the circulation under the influence of the regulatory hormone erythropoietin, which is produced by the peritubular lining cells in the kidneys, and it is very sensitive to tissue oxygenation. If tissue oxygenation is poor, then erythropoietin production is more. As expected, we want more red blood cell production, so that's how it happens. So, in the presence of adequate raw materials, the factory, which is our bone marrow, is able to produce the red blood cells on demand. And if there is a stress and if there is some sort of a reduction in tissue oxygenation, red blood cell production is expected to go up. So, when we look at anemia, decoding anemia is basically based upon these 4 concepts. One, we should have a good proliferative capacity of the bone marrow, and we should have both iron and availability of all the other nutrients, which includes B12, folic acid, and we should have adequate production of the regulatory hormone, which is erythropoietin, and we should have the ideal scenario for effective maturation of the red blood cells, precursors. They need to get matured under the influence of these regulatory hormones, thereby resulting in the final end product of a mature red blood cells. So 4 steps. We should have a good proliferative ability. Bone marrow the factory should be functioning quite well, and we should have good iron and other nutrient availabilities. We should have good production of the regulatory hormones of erythropoietin, and there should be an effective maturation of the red cell precursors. So if you look at free iron, is very toxic. So free iron cannot be roaming around. So it is the moment we have the intestinal brush border cells absorbing the iron, it is bound to transferrin, which is taking to the relevant tissues, wherein it is utilized for production of the red blood cells, which is our bone marrow. So the iron in circulation, after getting absorbed from the intestinal iron, is taken to the bone marrow, which is the factory where it is used for production of red blood cells. And the storage or the excessive iron is stored as ferritin inside the liver and various other places. Predominantly, transferrin is the protein which takes the iron and takes it to transports to various production sites or storage sites. That part we need to know. So transferrin will be an indirect marker of how various our iron levels are available in the blood. So if we can functionally classify anemia, we'll functionally classify as production defects. That is, the factory is not functioning well, factory being the bone marrow, whether the bone marrow production defect, which is a hypoproliferative marrow, and red cell maturation defects, which is ineffective erythropoiesis, and poor red cell survival, which happens because of blood loss and hemolysis. So if there is some peripheral destruction, or if the production is poor, or if the destruction is happening too much. So whether there is an imbalance between production and loss, net result will be a reduction in red blood cells, resulting in low hemoglobin. So when we look at the classification, how do we classify hypoproliferative anemia, which is in which there is absolute or relative bone marrow failure, in which erythroid marrow was not proliferated appropriately to the level of anemia. That is hypoproliferative bone marrows, in which there is anemia, and in response, the bone marrow has to divide or produce more red blood cells and should cope up for the net loss, but that's not happening. And it can happen in mild to moderate iron deficiency or due to inflammation, wherein the bone marrow is under stress of under various cytokines and chemical substances, wherein the bone marrow is not able to mount up the response which is expected, and it is not able to meet up to the demand. And there is suppression of erythropoietin. If there is suppression of erythropoietin, which happens in chronic kidney disease and due to inflammatory cytokines, we might not have a good regulator which increases the production of red blood cells. Thereby, we might not have a good proliferative net result in the bone marrow. And it generally is normocytic, or it can be microcytic as well. What are the other maturation defects? Maturation defects are divided into two groups. One is cytoplasmic maturation defects and nuclear maturation defects. Cytoplasmic maturation defects, the red blood cells look very small, which is microcytic. Nuclear maturation defects, the red blood cells will look big, which is macrocytic. And if there is a maturation defect, we tend to have an inappropriately low reticulocyte count. That is resulting in an ineffective erythropoiesis and destruction, or there is destruction of developing erythropoiesis in the bone marrow. That is by definition ineffective erythropoiesis. So classification wise, hypoproliferative, maturation defects, and blood loss, which is blood loss and hemolytic anemia. Blood loss is acute versus chronic. As gastroenterologists, we concentrate predominantly on chronic blood loss, which we'll talk about as we go on. Hemolytic anemia, even though there's so much of hype about it, but it is one of the rarest causes. I mean, it is the least common least common cause for anemia, and it will have a high reticulocyte count, and which is because there is too much of peripheral destruction of red blood cells. So the bone marrow will have to mount up a response. So retic count will be quite high, and we have to decide between intravascular and extravascular hemolysis. As we go on, the next few slides will elaborate on that. And this is one of the most important cartoons, and this is an algorithm for how we classify anemia. Anemia, the moment we see a person with low hemoglobin, we check for the entire complete blood count and the reticulocyte count index. The reticulocyte count is less than 2.5, and then the next step is to check into the red cell morphology, the red cell size, whether it is normocytic or microcytic or macrocytic. If it is normocytic and normochromic, which is the color and the size are normal, then it is indicating predominantly a hypoproliferative marrow, and that can be divided as two groups, where there is an absolute destruction of the bone marrow, where it is happening because of infiltration and fibrosis and aplasia, and there can be iron deficiency, which will also mild form presents as an hypoproliferation. And there is reduced stimulation or migration or stimulation of the factory, which can happen due to inflammation and metabolic defects and renal disease, wherein we are not having the adequate erythropoietin, which is the regulatory hormone which stimulates the production of red blood cells. So normocytic normochromic anemia, immediately we think about an hypoproliferative marrow, where there is an absolute deficiency of marrow functioning, or there is relative due to inflammation or not. That's what we allowed to think about. And if it is micro or macrocytic, we think about the maturation defect. Cytoplasmic maturation defects are iron deficiency anemia, thalassemia, and sideroblastic, wherein the cells will look small. If it is nuclear, the cells tend to look macrocytic, which is due to folate deficiency, B12, drug toxicity, or refractory anemia. And if the retic index is more than 2.5, we are expecting a hemolysis or a blood loss due to hemorrhage, which can happen, and that can be due to an intravascular hemolysis, metabolic defects, membrane abnormalities of the red blood cells, hemoglobinopathies, immune destruction, fragmentation hemolysis can all happen, resulting in intravascular versus extravascular. Extravascular is due fragmentation, all those things can happen. So how do we approach? If we have a patient who is coming to us with anemia, and we have to take a detailed history, symptomatology, symptom analysis. We should ask about the drug history, looking for any chronic usage of various medications which can result in a defective hemoglobin, and alcohol usages, and various alarm features in the form of, when it comes to GI, what are the most important alarm features? Unexplained weight loss, out of normal severe abdominal pain, persistent loss of appetite, nighttime symptoms, early satiety, altered bowel habits, motion which used to be normal earlier on, now all of a sudden becoming abnormal. One day is having normal stools, one day hard motion, one day semi-solid stools, one day no stools. Altered bowel habits in a person of the appropriate age is always considered major alarm feature, and loss of blood in the form of passing blood in stools or vomiting blood or low hemoglobin. So repeating loss of appetite and unexplained weight loss, persistent vomiting and severe abdominal pain, nighttime symptoms and early satiety, altered bowel habits and loss of blood. We come across any one of these GI related alarm features, it needs to be addressed accordingly, and based upon the age and based upon the presentation and the history, relevant investigations have to be evaluated. And if the person is elderly and if he's having progressive weight loss, and if he's passing some black stools or some blood in stools, or if his hemoglobin is low, and if it is looking predominantly like an iron deficiency anemia, straight away they need to undergo endoscopy. Upper and lower is what the way how we go about. But we will come across as we go to the next slides. Physical examination to look up for various parameters of hypervolemia due to low hemoglobin happening for a longer time, or certain hematological abnormalities can be picked up by significant lymph node enlargement and splenomegaly and hepatomegaly. Tachycardia and flow murmur across a systolic murmur can be reasoned out as a sign of hypervolemia in chronic anemia. So what are the important lab tests? We have got a panel of tests, but we are going to concentrate only on a few so that we'll be able to get a very quick clue and an overview about how to reason out anemia. What are the red cell indices? Hemoglobin, hematocrit, retic count, and other indices being mean corpuscular volume and hemoglobin and MCHC and RDW. White cell counts like differential and nuclear segmentation on neutrophils, platelet count and red cell morphology and anisotrosis, poikilocytosis, polychromasia, and iron studies, including iron, TIBC, and ferritin levels, marrow examination on relevant persons undergoing bone marrow, studies showing what is the morphology, we'll have to check for iron stains, and biopsy showing cellularity and various morphological abnormalities also need to be picked up. Amidst this, hemoglobin, hematocrit, platelet count, MCV, and peripheral smear, and iron studies are the most important ones which we need to go about. All those people are not going to go for a biopsy or a bone marrow study straight away. So mean corpuscular volume, peripheral smear showing an anisocytosis, which is variation in size, poikilocytosis, which is variation in shape, polychromasia, which is a slightly larger grayish blue hue cells, indicating reticulocytes, indicating production of more red blood cells. Sickle cells, nucleated RBCs, target cells tell us about abnormal maturation defects, and reticulocyte index will tell us about whether there is any hemolysis or not, and thereby there is a reactive production or hyperproliferative marrow producing more red blood cells. So iron studies are what is relevant when it comes to iron deficiency anemia. When it comes to GI, we are more oriented towards an iron deficiency anemia, because when we look at anemia, I classify as two. One, bone marrow being the factory, raw materials needed B12, folic acid, iron. Second cause for low hemoglobin is blood loss. So either the factory is not producing well or there is an increased loss. So the net product comes down. If it is bone marrow associated parameters, we look up for red blood cells, platelets, white cell counts, all. Some abnormality in the peripheral smear will be picked up, and that can be giving us a clue. It could be because of the bone marrow abnormality. Then the immediate next step is to check up for B12 and folic acid and iron ferritin levels. B12 folic acid, if they are low, cells tend to be macrocytic. If it is microcytic, we are predominantly thinking about iron. When it comes to iron, iron is a very, very easily available nutrient. A person of our socioeconomic status to be deficient in iron is very unlikely. So the moment we think about an iron deficiency anemia, we have to consider blood loss. And when it comes to blood loss, women and men, women premenopausal tend to have a period-induced blood loss. Men, it's predominantly GI. So the immediately moment we see iron deficiency anemia, we think about in the men, we have to think about blood loss and we have to investigate appropriately. So what are the common iron studies which we need to do? Serum iron indicates the amount of circulating iron that is bound to transferrin. Normal range is between 50 to 150 micrograms per deciliter. TIBC is total iron binding capacity. It is an indirect measure of the transferrin levels. Its normal range is between 300 to 360 micrograms. TSAT is transferrin saturation. If there is an iron deficiency anemia, TIBC goes up. More amount of the transferrin will be produced and its ability to combine will be more. Whereas TSAT indicates the percentage of transferrin that is actively occupied by iron. That is, it's an indirect way of it says the amount of saturated transferrin. Let's keep it that way. So percentage of transferrin that is actively occupied by iron, which can be calculated by total iron divided by TIBC into 100. The normal range is between 25 to 50%. And serum ferritin is the storage form of iron. So when it comes to iron studies, serum iron, serum ferritin, TIBC, TSAT, these four components we need to check. Out of this, iron and ferritin itself will give us a clue when it comes to GI component of it, because we are predominantly more oriented towards iron deficiency anemia. So when we think about iron deficiency anemia, it is commonly microcytic hypochromic anemia. Hemoglobin is less than 12, microcytic MCV being less than 80. So the moment we see microcytic anemia, the next step is to check for serum ferritin. If the serum ferritin levels are absolutely low, that is most definitive of an iron deficiency anemia. So immediately, based upon the appropriate age for females and for men, relevant investigations have to be done. Because microcytic hypochromic anemia, ferritin levels are low, you can take it as a definitive sign of an iron deficiency anemia. So you will have to work straight away accordingly for that. If the ferritin levels are normal or high, then we check about the TSAT and C-reactive protein. If the TSAT is low, which means percentage of saturated iron is less, and CRP is high, then it is due to functional iron deficiency, anemia due to inflammatory causes. And if the TSAT is high or normal, and if the CRP is normal, we will have to think about hemoglobin electrophoresis, or there is some sort of a distraction. And if hemoglobin electrophoresis shows an abnormality, we will have to think about thalassemia. If it is normal, we will have to think about the bone marrow problems and sideroblastic anemias. So the moment we see iron deficiency anemia, we suspect if we are seeing microcytic hypochromic anemia, the immediate next step is to check ferritin levels. If ferritin levels are low, it's an absolute, definitively it says it's iron deficiency anemia. So female and men, females, women, premenopausal, postmenopausal, premenopausal, relevant causes needs to be addressed. Postmenopausal, we will have to straight away go for upper GI endoscope and colonoscope. For men, iron deficiency anemia, straight away an upper GI endoscope and colonoscope. Doing a stool occult blood in a definitive form of iron deficiency anemia doesn't have any role. If we are thinking of iron deficiency anemia, we have to think about we have to straight away go for upper GI endoscope and colonoscope. So these are the various parameters which we come across in the conditions. In iron deficiency anemia, MCV, mean corpuscular volume, will be low, iron levels will be low, ferritin levels will be low, TIBC, of course, transferrin production will become more, so TIBC will be high. and transferrin saturation will be low because the amount of transferrin produced is so high, and if there is not much of an iron to get transferred, so TABC look, the TSAT will be less. In inflammatory anemia, the MCV can be normocytic or microcytic also, but it's generally normocytic. Iron deficiency will be there. Ferritin levels being a mark of ferritin is an acute phase reactant, you can have increased ferritin. TABC will be less. Transferrin level production is under inflammation is not happening well, so TSAT will also be low. In thalassemia minor, MCV is small, iron levels and ferritin levels, TABC all doesn't get altered. In thalassemia major, the similar presentation, but transferrin levels and ferritin production, ferritin production will be more, transferrin and TABC all will be less. So all we need to do in between, we have to differentiate between these first two components only. Rest all or will be straight away, telltales will be there. But the first two is what we need to differentiate between iron deficiency and inflammatory anemia. In iron deficiency anemia, ferritin levels are absolutely low. So normocytic, normochromic anemia, if the person's, when we see a hemoglobin of less but normocytic, then we immediately think about retic count. Retic count is increased, haptoglobin levels, low hemolytic anemia, normal or high anemia due to acute blood loss. If the reticulocyte count is less, we think about immediately we'll have to do ferritin levels, TSAT, TSH, creatinine levels, CRP, fibrinogen, various parameters. And if they're all abnormal, we'll have to think about other inflammatory conditions and renal insufficiencies, thyroid disease, chronic liver disease, all. If normal, myelogram and various infiltrative options have to be thought. Macrocytic anemia, if the MCV is more than 100, immediately we check the retic count. If it is increased, haptoglobin is low, hemolytic anemia. If it is normal, anemia due to acute hemorrhage. But if retic count is normal or decreased, we'll have to think about other maturity defects, B12, folic acid, thyroid test, all. If abnormal, appropriately, they have to be evaluated and deficiencies needs to be corrected. And if they are normal, then we'll have to think about bone marrow dysbiosis. So coming to our topic of iron deficiency anemia. Iron deficiency anemia, as I said earlier on, briefed repeatedly, the age in women and men, if we are thinking of iron deficiency anemia, microcytic, hypochromic and ferritin levels are low, immediately we have to think about progressive blood loss, which can be a trivial blood loss or a very obvious overt loss. So both the persons, if it is men and postmenopausal women, wherein the moment we think about iron deficiency, upper GI endoscope and colonoscope has to be done. There is no role for stool occult blood in the presence of iron deficiency anemia, and doing an occult blood and finding it to be negative does not preclude or does not give us a clearance that we are going to avoid doing an upper GI endoscope and colonoscope. So the moment we do an upper GI endoscope and colonoscope, if there is an obvious evidence of GI source, we have to treat that accordingly. And if there is no evidence of GI source, we'll have to treat with iron. And if there is a response, we observe. And if there is no response, we'll have to ideally go for a repeat. And then if that is also normal, we have to think about doing a capsule endoscope, which is to check for the 22 feet of small bowel. So when it comes to GI, we have to rule out blood loss from upper GI endoscope or the stomach, or we have got 22 feet of small bowel and we have got 1.5 to 1.8 meters of a colon. The moment we think about iron deficiency anemia, upper GI endoscope and colonoscope to rule out for any mucosal blood loss. If both are normal and if we are thinking about an occult GI bleed, the next logical step is to go ahead and do a capsule endoscopy. Before doing a capsule endoscopy, we do a CT enterogram to rule out any structurizing disease in the small bowel, and which rules out any narrowing in the small bowel, and then we go ahead and do a capsule endoscopy. If it is premenopausal woman, abnormal uterine bleeding, we'll have to treat accordingly and work up, and gynec related issues needs to be sorted out. If there is no abnormal uterine bleeding, we treat with iron. If there is no response, we have to think about occult GI blood loss, and we will have to go ahead and do the upper GI endoscope and colonoscope. I think we are open for questions. I hope I have given a reasonable brief. Oh, look.
Over to the audience.
Sir, what is the role of RDW? You said you're seeing for transfer in saturation, microcytic, poikilocytosis, all that. RDW, any role is there, sir?
Madam, that's all highly, we don't use the red cell distribution width and all for common things, but where that distribution width gives us an idea about the various sizes and shapes of red blood cells. And we don't commonly use an RDW for that. For us, we just stick to microcytic and hypochromic. The color and size is good enough for us, along with the ferritin and B12 folic acid levels, and we appropriately look into the age and look into the history and then reason out. What we come across in GI is predominantly iron B12 deficiency. So either micro or macrocytic is what we will go about. All the red cell indices are all, most of the indices or not even hematologists might be using, but we just stick to some basic parameters which will help us to reason out the problems in the right way.
Okay, sir. And what about megaloblastic anemia, sir? That is also one reason for the away from this hemolytic one, megaloblastic iron deficiency. Megaloblastic is also common in our place, no, sir?
Yes, madam. Megaloblastic also we come across. As I said, hemolytic is the least common. Macrocytic and microcytic. Microcytic is predominantly iron deficiency. Macrocytic means we think about B12 and thyroid disease and alcohol. In our practice, these are the common problems. And macrocytosis, we relevantly evaluate if there is history of alcohol or if the person's hypothyroid or B12. B12 meaning vegetarian dietary history, we take a detailed dietary history. A non-vegetarian being deficient on B12, then we think about is there any absorptive defect, because B12 is considered as a marker of absorption. So if we have a non-vegetarian who's B12 deficiency, then we immediately try to rule out an absorptive defect, which can be at the small bowel level, or if there is some autoimmune disease resulting in reduced production of intrinsic factor, thereby absorption of B12 doesn't happen that well. So when we see B12 deficiency, the dietary history helps, and if it is macrocytosis, our common causes are only these three: B12, thyroid, and alcohol.
Sir, one more question, sir, please. How to rule out this pernicious anemia in this chart, sir? Pernicious anemia.
Pernicious anemia will present as a B12 deficiency, and there will be a macrocytic anemia. So when we are thinking about pernicious anemia, one autoimmune disease, it's an autoimmune condition. Autoimmune conditions generally tend to come in groups. So if we are having a thyroid person, hypothyroid person, and diabetic, and who's a non-vegetarian and who's having vitamin B12 deficiency, then we think about an autoimmune mediated damage of the parietal cells, which result in production of which are major producing sites for intrinsic factor. So in pernicious anemia, we go ahead and check for various markers like the anti-parietal cell antibody and anti-intrinsic factor antibody. These two antibodies we check. And we do an upper GI endoscope and do multi-segment biopsies from the antrum and body of the stomach, and also from the fundus, to look up for any atrophic or autoimmune mediated gastritis or blunting of the absorptive surface also. And that will give us a reasonable idea whether we are dealing with pernicious anemia or not.
So nowadays, the hookworm-induced anemia is common, or it is changed in this era?
As I said to you, sir, pediatric age group, commonly worm infestations, macrocytosis, mildly elevated IgE, perianal itching, or recurrent abdominal pain, intermittent loose stools, all those things can happen, and in which case we try to deworm them, and relevant because there is competition for B12 and folic acid and other nutrients and iron, in which case predominantly worm infestations or iron deficiency usually. So we tend to treat those patients accordingly.
So when doing CBC, these changes in the platelet and WBC increasing, decreasing, how to correlate with this anemia, sir?
Okay. So when we look at increased platelet platelet count going up, in which case in GI it is considered a marker of inflammation. What we come across in inflammatory bowel disease, we tend to see a significant thrombocytosis if there is a flare up of the disease. So in IBD, if you are seeing a high platelet count, then it is indicating that there is some sort of an inflammation. So markers are whether the person is going for a flare, we address and we look into it. But when we look at the blood picture and we are having hemoglobin low, platelets low, and white cell counts are also low. If there is a reduction in all the cell lineages, then there are two options. One, either the bone marrow is not functioning well, or is there any peripheral destruction of if there is any peripheral destruction, which is commonest is hypersplenism, wherein you can have destruction of platelets, we can have destruction of red blood cells and hemoglobin also. So pancytopenia, first and biggest worry is whether the bone marrow is working well or not. Isolated increase in platelets alone, we think about some sort of an inflammatory condition. Fever with platelets low, white cell count low, hemoglobin disproportionately high, we think about hemoconcentration and bone marrow suppression secondary to viral infection. So it all depends upon how that person presents to you. Commonest presentation is low white cell count, low platelets, and hemoconcentration is one condition which happens typically with viral fever, commonly with dengue and other unclassified viruses also can present like this. Hemoglobin low, white cell counts normal, significant increase in platelets in a person, young person with altered bowel habits being treated for in IBD, then in those conditions, it is predominantly inflammatory conditions and flare up. If it is a chronic liver disease, patient can have low hemoglobin and white cell count can be normal, but platelets can be significant low. That is because of hypersplenism, because the spleen eats all the blood cells. And in that, the biggest blood cell being platelets, it gets caught very easily. So hypersplenism presenting as thrombocytopenia, anemia due to various causes in chronic liver disease, or viral infections and flare-up conditions.
Then for the hemopoiesis, in some book they are mentioning pyridoxine, zinc, copper is also important for hemopoiesis.
Yes, sir. Yes, sir. Yes, sir.
So how to rule out these other causes, these three?
Those are all micronutrients, sir. If you have the relevant issues, because common things are commoner. So if we are able to replace the basic components, they will be able to get corrected on their own. So copper metabolism abnormalities and all clinically to present as major disease is very unlikely, sir. In theory, they are required for production. Those micronutrient supplies will be adequate in our system, sir. So we don't need to worry. It is only the excess of those micronutrients. Like if we have Wilson's disease, then it's a copper metabolism induced abnormality. If you have any overload of these heavy metals, hemochromatosis, then they are all iron overload conditions. But correcting micronutrients to correct the hemoglobin are not very common. Prior to that, if we correct the major nutrient deficiencies, that itself will result in improvement of the numbers. We don't need to worry about that.
For this obese patient,
yes,
what is recommended is bariatric surgery. And before the short bowel syndrome, in this situation, how to correlate, sir?
Sir, bariatric surgery, olden days, is only volume reductive, and nowadays both volume reductive and bypass. Mini bypass meaning the first 60 centimeters of our small bowel is the most absorptive area of the small bowel. What they try to do is that they try to bring a loop beyond that and connect it to the stomach with the volume reduction of the stomach. It is basically some amount of malabsorption and some amount of volume reduction, which results in weight reduction. Nutrient deficiencies have to be periodically checked and have to be replaced appropriately. That is the guidelines. If you are going to have B12 deficiency because we are creating an artificial area of malabsorption. So invariably, some nutrients can get lost, which have to be appropriately replaced as the person goes on.
In chronic disease, the major involved area is the small intestine. So there is a possibility of the iron absorption problem. How to manage, sir?
Sir, in chronic inflammatory conditions, it is a suppression of the bone marrow due to various chemical substances, cytokines and all. Small bowel absorption is reasonably fine. Chronic inflammatory conditions, erythropoietin production might not happen well. Bone marrow suppression due to under chemical influences and cytokines, inflammatory cytokines can cause bone marrow hypoproliferation. Absorption through the small bowel is relatively good because iron is a very easily absorbed nutrient. It gets absorbed very quickly and very effectively. So in chronic inflammatory conditions, it is not the small bowel which is at fault, but it is the mobilization from the storage to production site under the influence of regulatory hormones which are under stress due to cytokines, which is causing the major trouble. So I don't think so. It's the small bowel which is at fault.
Okay, thank you, sir. Very much. Very nice.
So, one more question, sir. Role of ascorbic acid.
Vitamin C
absorption.
helps in the absorption of iron marrow.
Yes, but that can be used. Are you
We can
still
see
practicing?
it's a water soluble vitamin. So even if we take something in excess, that's fine because it gets excreted in the urine. We need to, when it comes to vitamin replacement, we are worried about the fat soluble vitamins, which is A, D, E, K. We cannot overdo those things because they have storage and they can cause hypervitaminosis and can cause more trouble. Whereas B complex vitamins and vitamin C are water soluble, so they get excreted in the urine. So we can comfortably, safely give. And they will not increase acidity and all in your stomach. They are quite good. Vitamin C is quite good.
The rheumatoid arthritis, it causes the bone marrow suppression. That is,
Yes,
they are
sir.
getting anemia.
Both inflammatory condition due to rheumatoid arthritis, and it is also an autoimmune condition. And third, medications which are used for also can cause bone marrow suppression. So it is a three-way attack in rheumatoid arthritis and all, which can result in anemia of chronic disease, painkillers causing blood loss, medications causing bone marrow suppression, immune-mediated damage causing bone marrow suppression as well.
So how to manage, sir, in this situation, very critical situation?
In that case, if it is rheumatoid arthritis, we will always, it's like how we go about doing any person with inflammatory conditions. First, we'll have to get the inflammation well under control. The disease has to be very well under control, and we have to need be replacement of the necessary nutrients has to be done, wherein they will be able to maintain the, if you get the inflammation well under control, it should happen quite well.
Oh, thank you, sir.
Any other questions?
Sir, yes, sir. Madam, actually, this is not to Dr. Bharat Kumar, it's to you and the rest of the group. Before Dr. Bharat Kumar came in, Dr. Rishad asked a very relevant question about this cough syrup issue. Now, I just want to know whether this cough syrup is not a generic problem with all cough syrups, right? A good company, I think we can trust and give it. It happened to because this company was not following GMP. So I just want Dr. Ravishankar and you to answer. Dr. Ravishankar is online?
Yes, Ranjit. Yes, Ranjit.
Yeah. So I just want to know, see, because in family practice, especially for dry coughs, dextromethorphan cough syrup works. And at least it gives you a good night's sleep. Now, question is, do we take this cold reef issue as a generic issue with all cough syrups, or with something that is very unfortunately unique to a few companies?
Right. It is not due to a few company or anything like that. There has been some manufacturing defect. What they said in what has come in the press is what has been given for a food product has been added to the pharma product. The concentration of certain chemicals has been so high that it resulted in the death of the child.
So they were not absolute poisons. One minute. They were not absolute poisons. It was because of the quantity, is it?
Concentration, pharma concentration and food concentration vary. That is what I have learned here.
Okay, right. Okay. Now, Dr. Ashwada asked a very relevant question. What is your answer to that?
Which one?
You were saying, what about the cough syrup? Can we use cough syrups or?
Except cod reef, you better use it.
Say that again.
Better not to use that. Srishan Pharma. I think Srishan Pharma is quite popular in our area.
No, ration was. I early when I started practice, people were coming, and now I stopped using
Yes,
ration. I don't
now
use
they
them.
are not coming. They are in manufacturing that has the
But companies like Abbott, all those things can be used. No problem. No
Yes,
balance.
no issue, no issue. I think
Okay.
you will get a much better answer for it on Thursday night when we have this.
Okay. Okay. Thank you. Because this is a family medicine issue. Related issue.
Correct.
Thank you
Bharat
very
sir,
much.
Yes, sir.
just capture for the sake of the people. This session will be kept as a recording in our IMCGP. I want you to brief 3 points in 3 different situations. An young girl coming with an anemia, the increased menstrual flow. What are the investigations you want in the blood?
In the blood.
Yeah. Your CBC and all these things. What is it?
So we have to, if it is blood flow, we have to just check for complete blood count showing microcytic anemia is what is expected in this young girl who is presenting with menorrhagia. And microcytic hypochromic anemia is what we are going to see. The next logical step is to check the ferritin levels. If the ferritin levels are absolutely low, then it's iron deficiency anemia, decent enough, and she has excessive flow, so straight away for a gynec reference. So that is how it will be.
It's going to
Can
be a
I-
middle age,
Sure.
35,
Sir,
40.
Bleeding time and clotting time. That also should be done, no, sir. It's a young girl.
Yeah, madam, but that will warrant for further workup when she is going for menorrhagia. So when she is going to get evaluated for menorrhagia, all those workup. But as he asked me briefly what to do next, so the microcytic hypochromic anemia, the next step is to check for ferritin levels. If the ferritin levels are absolutely low, it is iron deficiency anemia. So blood loss needs to be ruled out. Blood loss, young girl, have excessive bleed, then straight away guide.
Yeah. Thank you, sir.
Sir, Dr. Bharat, thank you, first of all, for a very wonderful talk. I'm hearing it for the second time. I actually came and complimented you at the end of the
Oh, yes, I do
talk
remember. Yes, sir.
One with a lot of face full of beard.
I remember, sir.
Okay. Now, sir, this is just a nomenclatural issue. Iron deficiency typically means deficiency of iron in food, right? Now, if there is a blood loss, actually iron loss anemia, sir. It's not iron deficiency. That's just a pure semantic issue. Just wanted to clarify.
Oh, yeah, correct. It's but then it is the level of blood levels which is deficient, which is prompting us to use the term iron deficiency.
Okay, but strictly speaking, it's iron loss anemia, not iron deficiency anemia, right?
Iron loss, this iron deficiency in the blood can be because of poor nutritional supplementation also. At the same time, excessive loss. So it can be an absorptive defect.
No, therapeutically, the reason why therapeutically, iron deficiency anemia can be probably treated by replacement of iron. But if it's due to iron loss, unless you treat the loss of the source of the point of loss of blood, mere replacement of iron is not going to help, no, sir.
Yes, if the container is leaking, without having the leak,
correct. In the hole, you can't do. Okay, right, sir.
You cannot.
Right.
That is one.
Thank you.
Iron deficiency can happen if it is nutritionally deficient also. And if for example, if you're having some absorptive defect, like a celiac disease or that part I have not dealt at all.
Okay. That's due to primarily intestinal issues. Okay.
You will have other issues also.
Iron being there in the food, but not being absorbed.
Yes, that is malabsorption.
A kind of an iron malabsorption syndrome, right?
Yes.
Okay, right, sir. Thank you, sir. You're absolutely. I'm still not able to understand how a gastroenterologist is speaking like a hematologist.
No.
You're speaking like a hematologist, but you're calling yourself a gastroenterologist.
No.
I felt the same thing.
I try to take pride in being a good physician, sir, first. So that is how we should be grounded in our
general knowledge. Absolutely fabulous, sir. Brilliant. Thank you so much.
Thank you very much, sir.
So my next question, 40.
Yes, sir.
Woman, male, active in his life, found to be anemic. How do you proceed doing the investigation?
Young or old male, sir?
45.
45, check for alarm features, check for iron deficiency anemia. Alarm features, history, iron deficiency anemia, straight away scopes, upper and lower. But 45-year-old male, anemic, coming to us as microcytic or macrocytic. Microcytic, iron indices low, upper GI endoscope, colonoscope. Relevant appropriate history, alcohol, thyroid, relevant history like that, then we think about looking in. Once again, if it is alcohol history, he definitely needs upper GI endoscope at least. So how the red cell indices are and how the history is, and always check for alarm features. If we have the slightest or the slight alarm features, always get some relevant investigations. Up the investigation, don't wait by giving anemia or by giving iron or by giving B12, or just if we see any alarm feature, get it evaluated completely.
Right. 60 plus
60
male,
plus,
female, 60 plus male or female. What
both
about investigations?
iron deficiency anemia, straight away they go for upper GI endoscope and colonoscope. Sir. No role for stool occult blood. There's no point trying to do a stool occult blood and being a reassurance if it is negative that there's nothing wrong. The moment you see a perimenopause, postmenopausal woman and male who is elderly presenting you with iron deficiency, even though they might be big made, they may not even have another alarm feature, straight away upper GI endoscope and colonoscope.
Ultrasound and peripheral smear. Where is their role in
Ultrasound all will come as a part of evaluation also, but should we push up to the level of upper GI endoscope and colonoscope means yes. Most of them will definitely have a basic health check. They would have come to you with, after getting an ultrasound, chest X-ray, echo, ECG and basic numbers, and in which case we would have seen a low hemoglobin and it might look microcytic. Trying to give some iron and waiting on that is what something which we should not do. We should go ahead and straight away refer for an upper GI endoscope and colonoscope.
So hyper, right? Carry on, Ravishankar. Finish.
On the therapeutic part,
Yes,
iron sucrose transfusion between the two. Where, what, and
I didn't get you, sir.
You have your iron supplement orally, plus you have an iron sucrose infusion.
Okay.
Between
plus
the
parental
two,
IM. Parental IM also is there.
Parental iron. Between the two, how do you choose your patients?
Okay, the level of anemia, ferritin stores. You check the ferritin stores. If the ferritin stores are very low, and if I'm having a person who's having inflammatory bowel disease in flare-up, trying to lose blood every time he passing motion, I might go ahead and give him a parental iron, IV iron. I prefer to give only in the emergency. I will prefer to give only in a hospital setting. I do not give it in a OP setting at all. I always prefer, because amidst 101 developing an anaphylactic reaction, we should be prepared for that. I give it in sucrose, maltose, whatever. I give it in 100 ml of normal saline, run over 1 hour in an emergency in a very protected environment. And if it is a mild anemia, oral iron is good enough. Any oral iron, I give them an option. I give them generally some options of a few brands. Whichever you tolerate, you please take. If you might have, and I might want them about some blackish discoloration and things like that. So in which case, certain people might tolerate a syrup form of iron beta, certain people might tolerate a capsule form or an iron tablet, and whatever suits them, I give it. And I follow up. If it is a mild one, and I follow up and I expect the hemoglobin to improve within a month's time. And if it is not improving, then we'll have to check again and see why it is not happening.
Thank you.
So what about based upon the severity, ferritin stores, and if and then we decide what we need to. And if it is a gynec-related issue, even though the hemoglobin becomes normal, I try to keep them on long-standing oral supplementation of iron, so that every month blood loss is getting filled up with the oral iron.
What about IM iron, sir? Intramuscular iron, parenteral?
I don't use that. It's predominantly gynec people who use. I think I don't use IM iron.
No, man. But that doesn't carry the same risk as the IV iron, right?
More than that, I think the malignancy that can happen on long duration is the one which has made the IM iron go out of the market almost, and we are now being supplemented with the intravenous sucrose infusion.
Repeat that, Ravishankar.
There are incidents of high level of sarcomas, post intramuscular iron.
Sarcomas, is it?
Yeah, I am not very sure about the malignancy, but there is incidence of malignancy in the intramuscular, and that is why it has almost gone obsolete in the market. We don't get the parenteral IM injection Amada madam, Yasoda madam.
Yes, sir. Yes, sir. You're right. You're right.
I will prefer only IV. IV
IV.
infusion.
That's the reason why of
Yes,
late,
sir.
I think in the last 10 years, iron infusions have started coming. Am I correct, Bharat Kumar sir?
I don't use IM injections, sir. I have not
Yeah,
used
yeah.
it.
I know that.
I have not.
You should have been
even
aware
ventured
working in
into
a corporate. You should be aware.
So when we were
that.
house surgeons, intravascular iron was a regular
Yes,
thing in the
yes,
ward.
yes.
Remember?
But
Yes,
used to be
yes,
very
Ranjit. Yes,
painful,
Ranjit.
sir.
That's
Very painful
perfect.
injections.
Very, very painful.
Very painful injections.
Next time
Yeah,
they
check
will not come.
Infron, all this has
And
gone.
it has
Infron injection.
B12 also used to be very
Midcofol, all
painful.
this.
Nowadays it has become water
All.
soluble, so it is a bit less painful, sir. Now, olden days it
painful.
used to be a very painful injection. Oil in
That's
my
because of the combination, yeah. Sir,
Yeah.
hypersplenism will already show it become splenomegaly, sir, or may he not have splenomegaly, hypersplenism?
Hypersplenism, by definition, functionally, the spleen should be more bigger. But
Bigger.
there are other autoimmune conditions where spleen can be normal and there can be immune mediated damage also. But hypersplenism per se, it is hyper functioning of the spleen, and hyper functioning of the spleen happens if the spleen becomes bigger. And the commonest being increased portal pressure, which is portal hypertension, commonest being cirrhosis of the liver. Isolated left-sided portal hypertension also can happen, but cirrhosis of the liver is the commonest reason for hypersplenism.
Okay.
Sir, what about ferric carboxymaltose, sir?
Ferric carboxymaltose is what is being used. That is the various brands which we use. So 500 milligrams, I give 2 weeks apart. 100 ml of normal saline, and infusion run over 1 hour.
Okay, sir. Sir, is this more bioavailability comparing to iron sucrose? Is it true, sir?
That's what they claim. They claim it is less allergic than other components. That's what was the reason why I tend to have some inclination towards this. But still, I've had one patient who developed an anaphylaxis following carboxymaltose, and that made us very, very aware that we have to be very careful. We can never take a chance. As he was in the ER, he was revived and things became better. Young male, but he did well. It was a short span. Immediately was resuscitated and taken care. So he was okay.
Okay, sir. Sir, in oral format, we have various types. For example, ferrous fumarate, ferrous ascorbate, ferrous bisglycinate. Is there anything?
I don't have any difference. I feel the net result, hemoglobin should get corrected. Patient should tolerate that well.
Okay, sir.
So,
No, sir. Among this, is there any comparison?
I have not keenly analyzed that component. I seriously don't know that. But I just give it as an oral form of iron. Various popular brands we try, and whatever helps, helps.
Okay, sir. Thank you, sir.
1973, British Medical Journal has reported incidence of sarcoma after repeated intramuscular injection. PubMed has given it. If it is in 1973, I think.
Oh, thank you for that information.
Articles.
Yes, sir. Yes, sir.
I mean, it is after repeated injections, is it?
Yes. Not one injection.
Right. Okay. Anyway, I think my contribution to this will be incomplete unless I thank Dr. Ravi Shankar for bringing this fantastic man into this group. Because the last time I heard him, I thought, I learned half and left other half. Today, I think I'm
just an
closer to
impressive.
Say that again.
Hematologist on hematology.
Yes, exactly. And such a humble person. I saw him that day. I mean, carrying so much of knowledge in it, and is so humble. Really, that speaks of you. That's a contribution to your spiritual element, sir. You're such a very knowledgeable and very humble. Thank you for being what you are.
Thank you very much, sir.
Madam.
Can you close it up?
Thank
you, Dr. Bharat, sir. Dean has left.
Dean is not there. I think
not here. Yeah. Thank you, Dr. Bharat, sir, for a wonderful presentation and nicely explained as well as patiently explained all our doubts and clearing all our doubts. Sir, we will have your talk in person in some other meeting, sir, in
Sure,
our
madam.
branch.
Definitely. We'll join you, madam.
Yes,
sir.
yes.
Yes, sir. That will be more beneficial to all of our branch members also, sir.
Yes,
Sure,
yes.
we'll do, madam.
I agree with you, with Dr. Amada. We must bring him to a branch one day.
Sure.
Thank you. Thank you, sir. Thank you.
Thank you.
Thank you very
Thank
much,
you
madam.
all the participants for your nice cooperation. Thank you, one and all.
Thank you.
Thank you, everybody.
Yes,
Thank you for a
Shall we
wonderful
close the
session.
meeting?
Yes, sir.
Yes.
Be there tomorrow also at the same time.
Yeah, the
Same time, is it?
by 3 o'clock, all of you are requested to join our
Mula madam,
new
konjam
course
WhatsApp la potrunga.
inauguration. We'll send the link to all.
Konjam indhula potrunga. WhatsApp la potrunga. Vandarom.
Sure.
Thank you. Thank you. Thank you very much.
Very much, sir. Thank you very much.
Thank you.